A 20-year-old male presents with persistent knee pain. I am showing you the anteroposterior and lateral radiographs of the knee. Describe the findings.
Right, so? The radiographs of the knee demonstrate a well-defined osteochondral defect along the lateral aspect of the medial femoral condyle. Within this subchondral defect lies a separate sclerotic bone fragment surrounded by a thin, lucent halo. There is no major joint space narrowing and no secondary degenerative osteoarthritis is identified. The location of the subchondral defect and the presence of the in-situ osteochondral fragment in a young male are highly characteristic of osteochondritis dissecans.
What is the differential diagnosis for a focal femoral condyle defect, and how do we differentiate them?
The primary differential diagnosis for a focal osteochondral defect of the femoral condyle is spontaneous osteonecrosis of the knee, also known as SONC. Spontaneous osteonecrosis typically affects elderly female patients, is acute in onset, and is located on the weight-bearing surface of the medial femoral condyle. Conversely, osteochondritis dissecans characteristically affects adolescents and young adults, has a male predilection, and is located on the non-weight-bearing lateral aspect of the medial femoral condyle. The mnemonic LAME helps remember this classic lateral aspect of the medial condyle location.
I am showing you the Sagittal T1 and T2 weighted magnetic resonance images of the knee. Describe the findings.
The sagittal T1 and T2 weighted magnetic resonance images of the knee demonstrate a traumatic osteochondral fracture along the anterior aspect of the lateral femoral condyle. There is a small osteochondral fragment that is mildly displaced, surrounded by a rim of high T2 signal fluid. Marked bone marrow edema is present in the adjacent subchondral bone of the lateral femoral condyle, indicating acute trauma. The presence of a high signal T2 fluid rim surrounding the fragment is a critical indicator of fragment instability and potential detachment into the joint space as a loose body.
Discuss the pathophysiology of osteochondritis dissecans and how magnetic resonance imaging evaluates its stability.
Osteochondritis dissecans is believed to result from repetitive subchondral microtrauma or fatigue fractures caused by shearing rotatory impaction forces, leading to localized osteonecrosis and cartilage fragmentation. Magnetic resonance imaging is the modality of choice to evaluate fragment stability. Features of instability include a high T2 signal fluid line tracking behind the fragment, multiple subchondral cysts beneath the lesion, cartilage breaches, or a focal fluid-filled osteochondral defect. If these signs are present, the fragment is considered unstable and prone to mechanical displacement.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these findings with prior radiographs to check for interval displacement or joint effusion. I would recommend a dedicated non-contrast MRI of the knee to definitively evaluate the cartilage integrity and determine the stability of the osteochondral fragment. I would also suggest checking for any intra-articular loose bodies that could cause joint locking. Finally, I would communicate the risk of fragment instability to the referring sports medicine or orthopedic surgical team to plan for arthroscopic stabilization or removal.